per minute. The patient was referred to the cath lab. On the left ventriculography, we have a normal left ventricle function. On the left coronary artery, we can observe two different lesions. A first long lesion and severe lesion on the mid part of the LED. We can also observe a second lesion, intermediate, on the left circumflex. On the right coronary artery, we have observed a very severe lesion of the second segment of the right coronary artery. And so we decide to treat this patient by a PCI with a stent implantation of the second segment of the right coronary artery. In terms of risk evaluation, the patient has a neuro score at 4.2% and a STS score at 7.6. And the syntax score was at 11. So the key points should be to discuss the strategy in case of an acute coronary syndrome of the management of a multivessel disease patient. Second point, we have to discuss the strategy for the LAD lesion treatment and at least discuss the strategy for the intermediate lesion of the circumflex artery.
Okay, thank you, Jean-François. So to summarize, this patient is a 73-year-old. He's diabetic. He has an acute coronary syndrome. He has the three-vessel, angiographically three-vessel disease. The culprit lesion was treated with a stent implantation on our RCA, and we have today to take care of the left coronary system, left coronary tree. And on this coronary tree, we have a significant, but it looks moderate angiographically lesion on the circumflex artery and the OM branch. And this critical lesion of LAD involving the diagonal branch. So maybe, Bruno, you can show us some views that you have done, explain what you are planning to do, and Martin, if you have any comment concerning the strategy in this patient with three angiographic vessels, and can we consider this patient with a really free vessel disease, or is there another type of evaluation to precise the best treatment option?
Okay, Jean, I will show now the angiography of this patient on the left coronary tree. You can see here the mild or the stenosis on the first obtuse marginal branch. We see a little bit better on this view. Don't seem to be critical. And now we can see better the lesion, the tight lesion on the middle AD with also an involvement of the main diagonal branch. As you can see also on the next view, this is a quite huge diagonal branch. Maybe as the territory supplied by this diagonal branch is so as important as for the LAD. And this diagonal branch is also a little bit diseased as its proximal portion, but the ostium seems to be free of disease. So what we intend to do today is to evaluate by FFR the...
So, any comment concerning this case?
I don't know what you are doing in Toulouse in real life every day. This is a non-ST, acute coronary syndrome. It's not ST elevation myocardial infarction. I think in ST, all of us, we do the culprit. If there is cardiogenic shock, do the whole.
Prolonged pain, chest pain at rest, elevation or troponin 0.11.
No, I mean now this we have anatomy.
No ST changes.
We do what the ST changes. We don't know in the anterior or the inferior. We don't have.
There is no.
Okay, so we don't know where is the culprit.
Absolutely.
Okay, so when this is diabetic patients, 72, we have 2 or 3 or 4 vessels. The only then the syntax score is 11. So now it's patients for PCI. So why you start with the right, you don't start with the left first? Because the more critical here is or you see in the stent boost, maybe sometimes you see a plaque, you assume this is a plaque rupture. This is my first question. The second, you do it in PCI in the elderly because you have a lot of elderly in France. We don't have a lot of elderly in the Middle East doing doing acute coronary syndrome. Usually our age from 60 to 70. More than 75, we don't have a lot of patients like you in Europe. So in these such kind of patients are used in all elderly patients. You go for doing multiple PCI for these patients, or?
So first of all, this one is not too old. It's 70, 73, something like that. 73. So there is no major contraindication for surgery. He has previous endarterectomy, but there was no major contraindication, and the Euroscore was correct. So in fact, if the surgeon in this case could bypass the right coronary artery, which was a huge dominant right coronary artery. This is the reason why we start by the right, because it was really an enormous vessel. It could bypass the right, it could bypass the OM branch and do a sequential graft on the LAD diagonal. So this was possible. It's possible. We have 3 conducts and 4 distal anastomosis, absolutely. So what we do, when we come back to the case, this patient was admitted quite late in the late afternoon. It was 7 p.m. And when it arrived directly, when we get the first dosage of the troponin at 0.11, we say, okay, we do directly we place directly on the cath lab. So he received high dose of Plavix. It's 600 milligram of Plavix, aspirin, low molecular weight heparin, and was placed directly to the cath lab. When the cath lab, we've seen this: good left ventricular function, the free vessel disease, and we saw this huge coronary artery with a high-grade lesion. And so the reason we decide to treat this, and then because the other lesion was suitable for PCI, we decide to do in the second step. The other point, the renal function was also a little bit impaired. This is the reason. But the patient will be more stable, and maybe coming at a different time of the day, it should be treated medically and discussed with the surgeon. I'm sure that 73 years old, it could be bypassed. Yeah. Any other comment?
Actually, John, I think the staging of a procedure is an issue. I mean, I don't know if we have a final say, except for ST elevation.
Yes.
And the first case we had, there was a clinical need to delay the second because he had a low creatinine clearance. So there was clearly a clinically driven reason for staging. In this particular case, staging, maybe, as you said, maybe logistical reasoning. Yeah. He came late and the staff was tired, and you're reasonably allowed to do that. Other than that, I mean, clinically, maybe there was no strong reason to stage him. Do you agree with me?
That's true.
Yeah.
No, the only point was the elevation of the troponin.
Yes.
We changed the strategy.
Do you cath all diabetic patients with acute coronary syndrome?
Excuse me? Do
you cath all diabetic patients with acute coronary syndrome in spite the troponin is negative, no dynamic changes?
Well, it depends. It depends. So we need sometimes we have no troponin, but you have significant changes in the ECG. But the other point is the patient is diabetic, so it's one of the criteria of high risk.
Just a short question about the syntax scoring system. Last year in EuroPCR in Barcelona, it was mentioned that it was under approval process to be, used. But now, is it now a routine that you'll score the lesions as a scoring system by syntax in your practice, Dr.
Yeah, I think that now since the result of the syntax trial and this score now is adopted by in general, all the population, and you will see in next beginning of September or late August during the next ESC meeting, and I invite you to join us in the Stockholm for ESC meeting. There will be the presentation of the guidelines on revascularization. And this is very nice because for the first time, it's guidelines not on PCI, it's not guidelines on surgery, it's guidelines on revascularization. And this guideline was written by the group of non-interventional cardiologists, interventional cardiologists, and surgical surgeons in association with the EACTS. So it's very interesting because this was really the consensus of all this group, and particularly with the surgeon involved in the decision for this guideline. And you will see concerning the revascularization in multivessel disease, the syntax score has a really great place now in the decision making for the patient. Question? Yes?
Yeah, that was a difficult question to answer. As I mean, there was no ECG or anything.
No ECG, no almost.
But maybe, you know, maybe the staging, the RCA maybe was a very simple lesion to fix. Was clearly a very tight lesion. So for logistical reasons, I mean, if this patient appears in your lab at 7 or 8 p.m.
We do it.
and you know, you're at the end of the day, you might just want to treat the RCA. You're not 100% sure it is the RCA, the culprit, or LAD, but RCA can be fixed in 5 minutes maybe. LAD takes another hour. So which one would you choose? I guess, is that the reasoning you go through?
Absolutely.
Yeah,
And
so
what's interesting in this case, which is you will see the progression of the case is quite provocative. It's there is two parts: the emergency situation, and this was done as we do in routine practice, and the rest, which was doing in the second step, was really more intellectual reasoning, etc. So it's totally different way of decision making for the same patient.
And John, maybe one thing I noticed myself, and I noticed my colleagues also, sometimes you yourself, with the same background knowledge, you will decide two different decisions in 2 different days, according to your mood, whether you had a complication the case before, whether you know you're tired, you just came from a vacation, and you're still in a vacation mood. I mean, I think there's lots of psychological factors would influence what you do in the cath lab, I think.
John.
Oh, thanks very much. Regarding the FFR, it's a rule in this case or no? Fraction from the reserve.
Yes.
To give us for a hint for example, which one will I do the BCI? For example, I have a lesion in the diagonal, I have a lesion in OM, other lesion. FFR, a rule, thank you very much.
You will get the answer. We go.
Thank you.
We move on.
Marginal branch, and then it's, I will say, the diagnostic part. So to classify if the marginal branch require or not treatment, and then see what we have to do for the LAD and even on the diagonal.
Yeah, the LAD diagonal is a very interesting lesion.
John, can you
guess
just
we'd
freeze
all
it here?
like not
Can you just freeze?
to have
Can
to
you freeze the
treat
LAD
the
diagonal and the areocranial?
And so maybe we should first of all do the FFR of the obtuse marginal of the circumflex territory, and
Everybody,
then
so I just wanted to ask.
You want to see again the lesion? We come back. We will try to come back.
That's okay. It's okay. I mean, everybody saw the LAD diagonal.
We can come back.
The LAD, as you could see, has a very tight lesion. The diagonal
Or
we
not
had-
treatment, and then see what we have to do for the LAD and even on the diagonal.
The other view.
yeah, the LAD diagonal is a very interesting
Okay.
lesion.
Stop. Okay, so this is the anatomy.